Thank you very much. Today I will be talking about sleep disorders in the geriatric population. And sleep disorders in this population are quite common, and 40% of this group are not pleased with the quality of their sleep, and they do have chronic sleep disorders. Although there might not be any physiological problem, certain changes occur in this geriatric population. Their total sleeping hours go down. Approximately 5 to 7 hours is enough for them, and sleep becomes fragmented, and nighttime awakenings also increase in number, and the duration also increase. So it is much more superficial in the aged people, and the REM goes down, non-REM 3 goes down, non-REM 1, 2 goes up, especially in males. In the suprachiasmatic nucleus, some physiological degeneration occurs due to age, and this decreases responsiveness to external stimuli, and melatonin release is also decreased. And as a result of this, early sleep phase syndrome occurs from the age of 60. Every 10 years, the beginning of sleep is 1 hour later. So they tend to sleep earlier, and they tend to wake up earlier. What are the sleep disorders in this population? Insomnia, respiratory disorder, circadian rhythm disorder, parasomnia. Insomnia are the most important and the majority of the problems in this group of people, and it is hard to maintain sleep, not being able to sleep enough, or not being able to sleep at all. There are nosological differences in the categories, so prevalence is different in this group of people. In the aged population, it is 20 to 40%, the prevalence of insomnia symptoms, but the insomnia diagnosis is only 5%. You can see the international categories of insomnia, the diagnostic criteria for insomnia. Insomnia symptoms may manifest itself with other psychiatric conditions. It might also result in depression. So there is a dual relationship here. Based on studies on neurocognitive difficulties, very interestingly, there is no distortion actually. There is this high cognitive impairment, but there are also studies that suggest just the contrary. Of course, cardiovascular diseases and the risk of cancer increase as you age, but what is their relationship with insomnia maybe can be checked later on. So what are the diagnostic methods? A sleeping journal can be kept, and then the duration to sleep, time to wake up, time to sleep, all those will be recorded in this journal. Actigraphy, we're not using it in our daily routine, but if there is circadian rhythm disorders, maybe we can use this to help the diagnosis. We do not need polysomnography for insomnia assessment. Sleep apnea, and if you think about other disorders like mobility disorders, maybe we can go for polysomnography. What do we do for treatment? Well, non-pharmacological approaches come at the forefront for this aged people. Sleep hygiene and cognitive behavioral therapy are the ones that are preferred mostly. Behavioral cognitive therapy is the first line of treatment in chronic insomnia. We do know the rules for sleep hygiene, and it is very important to come up with a good routine for sleep and good environment for sleep. But we have to always take into account that the patients may not abide by these rules. And another important point is that the sleep hygiene works at the first place, but it's not that effective as a monotherapy. So I would like to highlight that you can recommend your patients to wake up at the same hour every day, and they shouldn't compensate that for at the weekends. And cognitive behavioral therapy has proven to be effective in many studies, and there are maladaptive cognitions with regards to sleep. We have to take that into account. Limiting the sleep and relaxation techniques are very important as well. Stimuli controlled treatment. Those stimuli that do distort sleep and those that are not in accordance with sleep should be decreased. So we're here trying to organize and regulate sleep patterns and sleep habits. Those that are trying to, those that are having difficulty in initiating sleep, all these may help actually. And you should go to your bedroom when you feel sleepy, actually, not when you are tired. Sleep limitation treatment, this is also important in the aged people. They actually spend very long times on the bed, and we are trying to shorten this time. Benzodiazepines, I'm not going to cover them because they are not suggesting to use this in this aged group, in this aged people. Melatonin receptor agonists and melatonin, but not again suggested. Melatonin and melatonin agonists and antidepressants can be used. Benzodiazepine receptor agonists, so Piclon, it doesn't impact REM sleep, and REM1 sleep is decreased, and there is no significant change on REM3. Rebound insomnia effect is also lower. Melatonin taken 1 or 2 hours before you go to bed, and circadian cyclus happens at an earlier stage, plus the morning impacts are also very light. Also, it is regulatory if the circadian cycle is distorted. Agomelatine, it is a melatonergic receptor agonist, and it is H2,2C antagonist. But it's very important to look for hypersensitivity and liver enzymes. There are also studies for that as well. Rapaltone, it has been approved by FDA but not licensed in our country. It has a short effect, so for those patients that have circadian disorders, in majority we are opting for that. Together with depression, if the patient has insomnia, we suggest antidepressants. Doxepin is only approved by FDA, by the way, and they can be used at lower doses when compared to depression. So evidence-based suggestions are as follows. Pharmacotherapy together with cognitive behavioral therapy, antihistaminic, anticonvulsants, and antipsychotics shouldn't be used in the chronic treatment of insomnia. So antihistaminics, anticonvulsants, antipsychotics shouldn't be used, but cognitive behavioral therapy can be used. What about sleep apnea syndrome? It is arrest of respiration more than 10 seconds, snoring, and daytime sleepiness. Obstructive sleep apnea or central sleep apnea are two categories. In the obstructive one, there is an obstruction in the upper respiratory route, and in the central one, there are cardiac pauses. And we do have this severity scale. If it's more than 5, then it is sleep apnea, and then there is hypopnea index. According to that, the ratio changes in the aged people. For example, if the criteria is 5, it is 50%. If it is 15, then the prevalence for sleep apnea is 20%. In congestive heart failure, cerebrovascular diseases, and in other certain conditions, the risk for apnea increase. Other speakers also mentioned that obesity is a risk factor, but obesity in the aged people is no longer a risk factor. Actually, it's much more of a diminished one or a decreased one. The prevalence is equal from men to women in the geriatric population. Sleep apnea diagnosis is rather hard in the aged people because the clinical manifestation is kind of vague. 63% is the prevalence of sleep apnea in Alzheimer's patients. So if there's a cognitive impairment, the prevalence may go up. In heart failure, it is 13%, for example. So other comorbidities also increase in sleep apnea. Snoring is reported less in the geriatric population, which makes it more difficult for us to diagnose. So snoring reports over 65 years of age is in counter relationship with apnea. How are we going to diagnose? Polysomnography is golden standard in the diagnosis of sleep apnea, but of course physical exam should be done before polysomnography, and we do not need any lab work or any imaging technique. As I also stated, the risk factors should be decreased for treatment. Obesity and sleep apnea in the geriatric population are not in correlation with one another, and epidemiologic studies suggest that survival of the geriatric population or the aged people with higher rates increase. This is also interesting. But the most effective is CPAP, of course, in treatment, and when CPAP is administered continuously, the most important shortcoming is compliance. It is 40 to 50%. And this is the same for the geriatric population and for youth as well. Pharmacological treatment is non-existent for sleep apnea. Circadian rhythm disorders, as the most common form of that is early sleep phase disorders. They tend to wake up at an earlier phase than normal, and then they tend to go to bed at 6 to 9, between 6 to 9. They might wake up at 2 o'clock in the morning or 5 o'clock in the morning. This is 7%, its prevalence. Both genetic and behavioral factors are combined in this phenomena. Actigraphy can show that the sleep phase happens to begin at an earlier phase. How are we going to treat that? Chronotherapy, nighttime bright light treatment. Circadian rhythm change in the aged people is this irregular sleeping and awakening rhythm disorder. At least 3 times a day there are irregularities in the sleep patterns. There is no circadian rhythm, but when you add the sleeping hours, it is fragmented, but when they're added, it's normal. And the prevalence is unknown, but the target here, the target population is the geriatric population with dementia, especially those that are in a nursing house. And the causes is that abnormal circadian regulation and some environmental factors. And awakening and the sleeping cycles should be integrated. Exercise, social activities, and melatonin together with light therapy can work. REM sleep disorder, REM sleep behavioral disorder, we know that these people unfortunately do have nightmares, and they are living those, especially those that are male and above the age of 50. It is important because they might hurt themselves and their partners. Diagnostic criteria are as follows. Again, atonisis, non-atony anamnesis should be shown. It could be due to pathological diseases, and it could be due to antidepressants that were prescribed. Clonazepam is the most effective drug. Within the first week, the impact is observed. Your last 5 minutes. Thank you. Due to clonazepam, the development of tolerance is very low. Why? Because this is important, because once you discontinue, the symptoms are seen again. There are certain studies on melatonin, 3 to 12 milligram per day, and 30 minutes before sleeping. This could also be done. Another thing is restless leg syndrome. Again, undescribable abnormal sensation in the legs. There is this need to move the legs, and it is a nocturnal condition. It could be exacerbated. It is bilateral, especially localized on the knees and the ankles. Iron deficiency, uremia, neuropathy can be their secondary manifestation, but the primary manifestation, it's more of a familial problem, especially in females and in the geriatric population. We see it more. Low ferritin levels and renal failure, late stage renal failure, we see it more. We do not know the mechanism very well, so history, physical, neurological exam is done in order to diagnose. Iron deficiency is very important. If ferritin is below 45 microgram per liter, it is more prevalent. So what should we do? First of all, we should treat the iron deficiency. The serum ferritin level should be above 50. It's very important. Theophylline and caffeine should not be taken by the patients at later hours. Dopaminergic treatment is the first line of treatment. New dopamine receptor agonist ropinirole and pramipexole, having FDA approvals, these can be administered. Benzodiazepines do not have an impact actually. Anti-epileptics can be used as a second line of treatment, but we do not have an anti-epileptic which has been approved by FDA. Periodic leg movements, these are the movements of extremities during sleeping, especially for, in the lower extremities, like the dorsiflexor one. We see the prevalence of this in the age group as 4 to 11%, especially those that undergo dialysis. We see it more. There is no FDA approved drug for this treatment. We can use dopamine antagonists, and we should avoid antidepressants. So this is the approach, the diagnostic and treatment approach for sleep disorders for the geriatric population. Is it insomnia? If it's insomnia, is it an insomnic disorder or a circadian rhythm disorder? If there is oversleepness during daytime, maybe circadian rhythm disorders or insufficient sleep syndrome or others like hypersomnia or narcolepsy, these should be done. And we should always look for other phenomena like restless leg syndrome and so forth. So this is a video I would like to show.
gelmiyor herhalde. Siz basıyorsunuz değil mi? Kusura bakmayın, bekletiyorum. 2 tane videom vardı.
I had 2 videos, REM behavioral disorder and periodic leg syndrome. Of course, there might be these inconveniences when it comes to videos. I'm sorry for that, and we are way behind our schedule, by the way.